Welcome to Oncology Today, key presentations from the December 2024 American Society of Hematology annual meeting, Non-Hodgkin Lymphoma edition. This is medical oncologist Dr. Neil Love. For this program, I met with Dr. John Leonard from the Weill Cornell Medicine and New York Presbyterian Hospital in New York City. At ASH, one of the data sets we saw presented was the 5-year analysis of the POLARIX trial of frontline polatuzumab vedotin in diffuse large B-cell lymphoma. And to begin, I asked Dr. Leonard how he approaches the use of this regimen.
Yeah, I think it's a great question. I'm using a fair amount of polatuzumab in patients if we have access to it, and we generally do. You could argue that a patient who has the germinal center subtype might not need it, but we have a positive study for all patients, so I think it's something that you could argue that everybody should get it, but clearly in the patients that are the non-germinal center or activated B-cell subtype, that's really the group that we're focused in on. I would also say that a lot of these patients are older patients, and you will see non-germinal center subtype patients that are frailer patients, and you could argue in practice, if you didn't have a trial, to use mini R-CHP swapping in polatuzumab as well. There's not as much data on that, but it's really kind of intuitive that would make sense if the tolerability is the same. I am excited, as you say, there are a number of new trials. There are still trials adding in BTK inhibitors to see if you can improve outcomes in that non-germinal center subtype. But I think, it's been interesting in large cell. It's kind of this polarity. In oncology, we like precision oncology, and across solid tumors, you have the subsets based on different molecular profiles and what drug works in what subset. On the other hand, you have these kind of agnostic treatments, the immunotherapies that, you use CAR T cells, you use bispecifics, and maybe they work a little better, a little worse in one subset or another. But really, you can use them in everybody, and they're active and effective in everybody, regardless of what subset they have. And so I think, what we're seeing in large cell lymphoma is almost a back to the future a little bit, where it's like, well, let's use a bispecific or CAR T as consolidation and just do it across the subtypes, because those seem to be relevant drugs regardless of the subtype.
It's funny, of course, I've seen the POLARIX data presented so many times in our programs, and you presented the 5-year follow-up, and I was just trying to remind myself of the hazard rate. It was 0.73, so usually when you see trials of hazard rates of PFS of 0.73, you don't necessarily get that excited. But then I was looking at that curve and thinking about the fact that kind of looks sort of like the cure rate. When you talk about 5% extra here, this is not 5%, extra months. I guess you could look at this and say, are you curing 5% more people, which, is pretty significant bite out of the people who aren't being cured.
Yeah, I think you're right. And I think, at the end of the day, you're saving people CAR T cells, you're saving people auto transplants. It may be somewhere between 1 out of 15 and 1 out of 20 people, but if you're that one person, it's hard to argue against trying to avoid being that one person.
Well, I guess I'm looking at through the old diffuse large B-cell model, where if you didn't cure people up front, you didn't have much of a chance of at least very prolonged survival, and that's totally going out the window with CAR T and the bispecific. So maybe I'm not even seeing this the right way, but getting back is a very critical, practical decision that kind of bothers me a little bit in terms of the cell of origin. I want to put this out to you. One of the concerns I have, and I'm still trying to figure out exactly what goes on, particularly in the community, in terms of cell of origin testing. So I guess one question is, can the typical general medical oncologist in practice trust what they see when somebody reads something as cell of origin? I noticed that in the cell of origin data with POLARIX, it was nanostring. What is that? It's not IHC, right?
Right. So So you're getting at, and we could spend hours talking about the subsetting of large cell lymphoma. And in fact, some of the purists would say, why are you even talking about these two categories? Because they're not really biologic. They're at this point kind of descriptive, and there are so many unclassified patients, which is another kind of point, because you have unclassified patients that you really don't know what group they fall into. And we know that there are now different subsets and further subsets, which has made all of trying to do targeted therapy more complicated, because you have more subsets and more than targets for the subsets, and then more challenges in knowing what subset a person falls into. So just that fact alone, plus the concerns that you mentioned that, again, some pathologists may not be as robust at doing this, that's an argument to give everybody polatuzumab, because you really don't know what you're dealing with. But that being said, the immunohistochemistry is a surrogate for cell of origin, as it's been defined for the molecular profiling. That's pretty good. And the nanostring is really a molecular test that is out there. It's not one that's available in practice. So again, there's been similar data. The slide had nanostring on it, but there's an immunohistochemistry algorithm, the Hans criteria that people may have heard of over years, that is pretty good based on a couple different immunohistochemistry markers at putting a patient into one group or another. So, you highlight the uncertainty of all of this, which some would argue says, well, since we really can't be sure and there are different ways of doing this, maybe since we have a positive study, that to go on the study, you didn't have to have one group or the other, and the group as a whole benefited, maybe lean in that direction.
Do we know at a national level, at least in this country, the reliability or the quality control of cell of origin testing that's in the community right now? Has anybody looked at that?
Yeah, I think some of the original studies, so I would say no. The short answer is no. I think that, and probably that evolves based on, where, if you're using a centralized lab or a local hospital pathologist and how often they do that. But there's an inherent uncertainty in all that, which is, I think, important to keep in mind.
So another related question, and now that we've had a little maturity, now that the data's been out there, this treatment has been used, from your point of view, is there any particular downside to using pola R-CHP? Is it harder to access? Is it more expensive, more inconvenient, more toxic? Any downside?
The study really looked at this carefully. One thing that I was very interested in when I looked at the initial reports was the neuropathy, because we know that antibody drug conjugates tend to give neuropathy, and polatuzumab, that was in the initial studies one of the big side effects. I think when you do the comparison study, it's basically the same to vincristine, which perhaps, we know vincristine gives toxicity, but maybe we don't. And I've been part of other large cell lymphoma studies, and I can tell you, I don't think we do a great job of capturing vincristine neuropathy. I think our patients live with it, and we kind of miss it often in practice and often in our clinical trials when you see that incidents reported and other things. But the bottom line is that it was no different in this study, which is reassuring. There was a little bit more febrile neutropenia. I think, if you have a higher risk patient, an older patient, where you'd be using growth factors, I think that would be somebody where you'd be sure to use growth factors with polatuzumab. But beyond that, it's really quite similar.
Well, yeah, I'm interested in looking at this more. I'm hoping we can maybe ourselves try to figure a little bit more out about it. I guess the one thing I was thinking is, to me, if somebody wants to use cell of origin to help make a decision, it's hard to argue against it. But I kind of wonder whether any patient getting first-line therapy, if the doc thinks that R-CHOP is appropriate, should maybe have pola R-CHP at least brought up as an option. There is another therapy. It looks maybe a little bit better. Maybe it won't matter in the long run. I'm basing this on a test that I'm not sure the result of. I don't know about that part. I want to ask also about bispecifics in diffuse large B cell. First, staying on the thing with diffuse large B cell, first line. Those data on first line bispecifics that you showed, I think it was with glofitamab and odronextamab, were pretty impressive. I know, there's tolerability issues, but if I had a 90-plus-year-old patient there with a lot of comorbidities, I don't know how that would stack up in terms of tolerability versus mini R-CHOP, or effectiveness? You tell me.
Yeah. I think it's a good question. I mean, I've treated 90-year-olds with mini R-CHOP, and I think I've cured a few of them, but it's not a picnic. And I tell people that you're really, most of those patients don't finish with what they started with. They might start with standard mini R-CHOP, and then you're spacing it out or reducing doxorubicin or something else. So, you look at 10 patients and they kind of have 10 different pathways with older, frailer, large cell lymphoma patients. So I think it's hard. It's very hard to compare those results. I think it's encouraging. I think it's to some degree for the patient, like what you're more worried about. Cytokine release in a 90-year-old might not be a picnic either. And, if they have to come into the emergency room into the middle of the night with fevers and mental status changes, you've got a mess on your hands at that point. On the other hand, you still mini R-CHOP for somebody who you've chosen mini R-CHOP for is not without its pitfalls either. So to me, I think the takeaway is really that that it's another option, right? So that you can look at things and go forward. To me, the interesting question is, can you cure a patient with a bispecific antibody? And my bet is that you probably can cure some patients. They came along after CAR T cells, but if they came along before CAR T cells, you'd have some patients out there 5 years from a bispecific saying this is the new curative therapy, and CAR T cells would have to beat it. And now we're left with the other way around. I think, to me, an important thing in large cell lymphoma is that this is an option for the community. And I think your audience includes a lot of people who CAR T cells are just not practical, based on patient preferences, distance, et cetera. And if you can get comfortable with and have the ability to give a bispecific in a community practice, I think that really is an option for your patients. And to me, the data with glofitamab with GEMOX, I think is another example that if you have an elderly patient and you live in a rural area where going to get CAR T cells is not practical, to be able to at least offer that to a patient, some people would find that a nice option.
Staying on diffuse large B cell and now focusing on relapse disease, one question again that's been heavily debated is in patients who are eligible for both CAR T and bispecifics, what comes first? And a sort of a corollary to that is how you view currently eligibility for CAR T, again, in a patient with diffuse large B cell, particularly in terms of comorbidities, even age, even though it's supposedly just a number, but sometimes it gets beyond that. So first, who do you consider not eligible for CAR T nowadays? And in patients who are eligible for both, how do you decide what comes first? CAR T or bispecifics?
Great question. I think that, I try to essentially, so if someone with relapsed large cell lymphoma, that CAR T cell cures a fraction of patients, and that bispecifics can give long remissions in a fraction of patients. My take is that CAR T cells are probably better at doing that, but they have more toxicity, obviously. And so the other take-home point is that someone who's ineligible for an auto transplant might be eligible for CAR T because it is easier. It's not a picnic necessarily to do CAR T, but it's easier than an auto transplant. And so I try to refer everybody who's got relapsed large cell lymphoma. Now, I might, a wheelchair-bound 90-year-old, obviously, there's some extremes there. But as much as possible, I will send the patient with relapsed large cell lymphoma for at least a consultation, so that they hear what's involved with CAR T, and some of them come back and say, I want to put that off as long as possible if I can get away with something else, but also to get a full evaluation. So I think a lot more patients are eligible for CAR T than auto transplant, and therefore I generally do that first. That being said, I would love to see a study with an overall survival endpoint where you randomize to CAR T versus bispecific and then a crossover, so that you can see where things settle. Do you end up, if you think that many patients are going to get one, and then if it doesn't work, get the other, does the sequence matter there? And I would love to do that study. I think ultimately it would probably show that you could do pretty well either way. That would be my take.
Yeah, and of course, one thing about CAR T is it's nice to be off treatment. So you have to get through it, but after that, at least maybe a little bit less of a hassle. So getting back now to bispecifics, whether they've had CAR T or not, I kind of call this have you ever heard of SERDs in breast cancer? There's like 5 of them. I think it seems like one's getting approved every day. I call this the oral SERD argument. So maybe more of a, because now in oncology, we're so often seeing multiple agents in the same class. Could you give us, let's start out with diffuse large B-cell and the bispecifics that have been looked at the most there. Can you kind of provide sort of a 35,000 square foot view of how they vary in terms of, the way they're used, whether it's short-term, long-term, sub-Q, IV, effectiveness, tolerability, and also, why odronextamab is not approved, because it looks pretty similar from what I can see. Is it going to be approved? And let's include that in the discussion, even though it's not approved in the U.S.
Great. So generally speaking, we have mosunetuzumab available for follicular lymphoma. We have glofitamab available for large cell lymphoma, and we have epcoritamab available for both. And there's some nuances as to lines of therapy, et cetera, but that's kind of the gist there. The data with epcoritamab is more around sub-Q therapy and more around indefinite therapy or longer term therapy, a bit longer. The data around mosunetuzumab and glofitamab are for some patients a fixed duration therapy, and generally speaking, IV therapy, although there are studies with those agents, particularly mosunetuzumab, looking at sub-Q also. So biggest differences are sub-Q versus IV, little bit about what's given with it. Glofitamab gets obinutuzumab with it to try to minimize the toxicity, et cetera. I think that like radioimmunotherapy, going back to days I can remember years ago meeting with you and talking about,
Right.
tafasitamab and yttrium based compounds, tafasitamab and
It's coming back in
ibritumab
prostate
deruxtecan.
cancer.
Yeah.
It came back in prostate
they're more similar
cancer.
than they're different. They're more similar than they're different, I think. And when you try to tease out efficacy, you'll see at different meetings, one group of investigators and companies zeroing in on one or the other. I think for someone who doesn't do this very often and is focused on other things, to me, the takeaway is, where should you be thinking about a bispecific? And then, I think learning the details and having your staff, your nursing staff and others learn one versus the other and just kind of getting the drill down a little bit. It's probably more important that you're comfortable with one and use that for a couple things than, one for one thing and one for another thing and have to keep them straight. And so I would look at your practice if you're in the community and say, well, which one am I going to use more, and focus in on that one.
What about odronextamab? Do you expect it to become available? Looking at the data, does it look much different than the other ones that you just mentioned?
Yeah, so odronextamab, I think, is very, very similar. There are subsets of patients where there are hints maybe of differentiation, such as marginal zone lymphoma. There have been some data at ASH that I was excited about, suggesting that it could be useful in marginal zone. We have a little less data in marginal zone with some of the other compounds. I think in the clinical development, there were some infectious complications that kind of slowed things down. I'm not sure if that's necessarily a real difference or just bad luck, but that kind of slowed down the process. I can't really judge that. But I think it's very comparable, very similar. That's kind of my gestalt around it. One thing that I will say about odronextamab and the trials, I presented a couple of the trials that are there. The questions that are set up with odronextamab in some of the trials are really kind of fundamental questions. So I showed you data of comparing odronextamab to chemo R. I mean, that's like a fundamental question. Not so much, well, does
Absolutely.
it work on a few people or how does it work up front? But is this really going to potentially replace, or how does it compare to a standard therapy that people are using every day? And I think, I'm excited that with some time, those are not ready for prime time as far as the data, but I'm excited that with time, we'll really have some very fundamental answers to these key questions of, can we swap these in for our standard therapies, which will be quite interesting to see.
Yeah, it's really a challenge for us out here trying to look at these things and, get a feel from you all. Are they pretty much, it's hard to distinguish, particularly in terms of efficacy? And when you think about the mechanism of action, is there anything different? I was kind of struck by this new one, AZD0486. I don't know if it has a name or not. Is there anything different about the way it's made, or is it similar to the other ones that we've been talking about?
I think that, so first of all, it targets CD19. We know CD19 is a target
Right.
for other B-cell lymphomas. We have Tafasitamab that targets CD19. We have CAR T cells that target CD19. So far, they haven't really interfered with each other. Like, you shouldn't necessarily be afraid to use one because you're going to get resistance or select CD19 negative cells, but that's always something that's in the back of the mind. There's some tweaks on it that, at least from the company perspective, maybe it engages T cells a little bit differently. We'll have to see if that translates out into really a clinically meaningful difference.
So, any thought about whether or not it'd be more likely to see a response to this new agent that's targeting CD19 after a bispecific that targets CD20?
I think that'll be an interesting question, and probably one path to develop this agent, this type of agent. So I think we will see, certainly going after a different target, and one that's not CD20 that patients have seen multiple times with other CD20 directed agents will be interesting and relevant.
So let's talk a little bit about follicular lymphoma and keep this discussion going about bispecifics. And again, particularly curious about mosunetuzumab. I keep hearing people say this is a great agent to be used in the community. You presented this really cool trial I hadn't heard about before, randomizing it versus rituximab alone in lower risk patients. I'm curious if you have any additional thoughts about that trial. But what I'm really curious about is, do you see any obstacle to a doc in community-based practice, maybe not even in a big practice, a small practice, starting mosunetuzumab on a patient with follicular lymphoma, or should they have it started at a tertiary center? And if they are going to start it, like, do they need to have tocilizumab in their office?
Yeah. So great practical question. I think that the good part is that the reactions tend to be manageable, and a fairly small percentage of people need tocilizumab. And they tend to happen relatively early in the first month of treatment. So if somebody says, I don't want to deal with this first part, I'm a little nervous, go to the tertiary, and then for the second month and beyond, every 3 weeks, the patient's coming in locally, or every 2 weeks, depending on the agent. I think that's a very reasonable approach if that works for somebody in practice. I think if you're going to do it yourself, people can do it themselves. I mean, I can think of the patients I've treated, and most of them who have a reaction, first of all, most of them don't have a problem and need to come in, but most of those that do come in manage with steroids, and I think most people are pretty comfortable dealing with dexamethasone. But you do have to have good prep for the patient so that they know what to do if they get a fever or have symptoms. And then obviously your coverage, or you need to know what to do if the patient calls at night. But I think it's a manageable thing for most people. And I think the companies have all done a pretty good job of prepping, giving you information to give to the patient, et cetera, to get that set. And I think, to their credit, and obviously it's in their interest to make sure it goes smoothly for people, I think that's generally worked pretty well.
So I'm curious what your current take is, your current approach outside of protocol setting, your current favorite trials, what used to be a much simpler discussion, second line therapy of follicular lymphoma. So, first of all, this TAFA R squared trial got a lot of people interested. Obviously, the data looks pretty interesting. You brought up the question of sort of what it's like for the patient experience. Can you talk about how you think through this new opportunity or new data set? Have you used it? Are you offering it to patients? What kind of patients? What do you think the ideal second line therapy is? Do you think it's actually not even R squared or R squared TAFA, but a bispecific?
Great question. I think that it really depends on the nature of the patient's disease. If the patient had a lot of therapy, they had R-Benda or R-CHOP or some version of that. Um, I think that, and they had a relatively short remission. I'm very worried about transformation, and I'm chasing after transformation with a biopsy, and that's got to be 1, 2, and 3. If you have an early progressor within 2 years, look for transformation, and then if you find it, you're going to approach that. Now, interestingly, we and others have used PET scans to look for transformation, and often you have a very high SUV, and you're sure that patient's transformed, and they don't have transformation. So that's an interesting sort of thing, but you really do have to rule it out as a practical perspective. My sense is that if someone had single agent rituximab, as upfront therapy, I'm very commonly using BR as an example for second line therapy, or R squared as second line therapy, depending on what the patient wants to do. I think if someone had a long remission to their upfront therapy, you can do kind of whatever you want to do. And I think of follicular lymphoma, my joke with patients is that large cell lymphoma is a dictatorship. We tell the patient, basically, this is what you're going to do. You're going to get R-CHOP or some version of that. And follicular lymphoma is a negotiation or a collaboration with the patient about, what's going to work for them. And if someone had a long first remission, I'm likely to give them R squared. I think it's a pretty easy regimen for most people, and it's a pretty effective regimen for most people. I think the idea of and frankly, the therapy is 6 months because you're getting the rituximab, over 6 months more or less, and then another 6 months of just the lenalidomide. So it's a pretty manageable thing. I think that I have not used the TAFA R square. I'd used tafasitamab with lenalidomide in large cell lymphoma, where it's been approved for a while. And if that's something you've used in large cell lymphoma for patients, you're probably going to be more comfortable also adapting, a version of that in follicular lymphoma. I probably would use that a little bit more in patients with shorter remissions, because I think that's a lot of therapy. I mean, most of my second line patients with follicular lymphoma need therapy, but are feeling pretty good, or trying to work, or trying to travel, or have family that are navigating getting them in. And I think it's a lot of therapy over the course of a year to be coming in so frequently. So I would probably use that only in people who, really needed that, where they had more resistant disease, et cetera. And then I think bispecifics really are my third line therapy for the most part, for most patients. They're generally approved, and we have a lot of data for third line approaches, and I think they're good options, and they can rescue patients. We also have zanubrutinib, obinutuzumab, is also approved for that, and that's something that I've been in occasional patients trying, and frankly a little pleasantly surprised that could be useful for some people. And then I'm saving CAR T cells for later line therapy, and for most people with follicular lymphoma, with the exception of people who do have transformed disease, where I go to that earlier.
When you have a patient like you described with follicular lymphoma who kind of has some hints of transformation but no proof of it, if you're going to use a bispecific, I've heard people say in that situation, maybe they would use one of the bispecifics that you use with both. So like you've got this kind of interesting dichotomy of mosunetuzumab and glofitamab, FL, diffuse large, but EPCO and I guess odronextamab sort of kind of work, or at least there's data with both. Would you tend to use one of those more than the ones that we're more conventionally using for FL, like mosunetuzumab?
I think that makes sense. On the other hand, I think the bispecifics are the approvals they have, from my perspective. Some of that is just kind of was the regulatory strategy of Mosun went in one direction, but We
Right.
have data that it can work in large cell lymphoma, and glofitamab can work in follicular lymphoma. So, some of that is an artifact of how the companies approach the approval
Right.
setting and kind of how
Right.
they navigated it. But that said, you do make a good point, and that may be easier to get going. And for people who don't use these very often, using one agent that can kind of cover both bases is probably a reasonable strategy, because you don't have to figure out 3 drugs. You can use one.
You mentioned Tafasitamab and diffuse large B cell. In what situations are you using it, and what have you observed in terms of efficacy and tolerability?
Yeah, I think what we've learned with Tafasitamab is that some of the follow-up data with that suggests that it's more valuable in patients with relapsed disease rather than more refractory disease. So, I think the setting where that's most useful is in elderly patients, frailer patients who are not going to get a more aggressive approach, not going to get CAR T cells, and where that's an option, but less so in the patients with, a short remission from their previous therapy. How you would compare that to a bispecific, I think, is a question. I think now that we have more and more bispecifics available, my sense is that those are more effective for that patient population. But certainly a frailer patient, that would come into play perhaps even before a bispecific or after.
So you mentioned the Zanu obinutuzumab regimen. What kind of, I've sort of seen hints of BTK and lymphoma, but not too exciting, at least from my point of view. And then this thing comes out like, whoa, where did that come from? So does this make sense to you? Do BTK inhibitors have activity in FL or non-Hodgkin lymphoma?
So there were some initial studies looking at BTK inhibitors in follicular lymphoma specifically. I mean, they're available in Waldenstrom's, in mantle cell, in marginal zone. Different agents are approved and available. There was some limited data in follicular lymphoma that I agree with you, I was not very impressed with. But then we had a study in recurrent follicular lymphoma comparing obinutuzumab and zanubrutinib, and those results were pretty good results. A positive study leading to an approval. And there are an occasional patient who's been through, where I think about that as after R squared. If somebody is after R squared, that's where I use it. I have occasional young patients. I've had a couple of young women who lenalidomide was not an easy drug to deal with because of the reproductive risks there and other things, or people who had been through bispecifics who didn't want to go to CAR T. I've gotten mileage out of it. I saw a patient who's been through a lot of different things. I saw him just yesterday, who was getting he had been through mosunetuzumab, he'd been through CAR T in the past, he'd been through R squared, and he was getting, he just told me he was skiing all winter, so that surprised me a little bit, but there are occasional patients who can benefit from that. So,
Getting back to bispecifics, what are some of the key longer term issues that, again, a community based oncologist might need to consider if they're following a patient, whether they got started by them or not? And one thing in particular I'm really curious about is risk of infection, use of preemptive anti-infectives, vaccination. What do you see with bispecifics? How much of an issue is this?
that's becoming more and more of an issue. I think we initially recognized that with CAR T cells, which obviously have some of the same immunosuppressive effects. I think the takeaway message, which I think people have gotten through other contexts, including COVID, is to the best you can vaccinate the patient, for flu, for pneumavax, for COVID before treatment rather than after treatment. If you can do that, sometimes you can't do that for various reasons. I'm actually part of an analysis which our group at Cornell is submitting, it's kind of a meta-analysis, for lack of a better term, suggesting that bispecifics and CAR T cells are not all that different in these long-term infectious complications. And one might argue, going back to a point you mentioned earlier, kind of the one and done, that bispecifics are chronic therapy. They may be less immunosuppressive, but they're immunosuppressive for longer in some ways because the patient's on them for longer. And so when you look at kind of the area under the curve of how long and how much immunosuppression the patient's going to have, it may actually be worse with a bispecific, or at least similar, because of the duration of therapy. But you're right. Issues that people need to be aware of is largely around long-term B cell depletion and issues of responsiveness to vaccines, immunoglobulin depletion, et cetera. And those are key issues. I think that the takeaway is, if a patient is getting chronic infections, like in other contexts, think about IVIG supplementation to be able to manage the patient and be prepared for that. I think it's also a lesson that you have to look at these studies, and I alluded to it briefly. When you look at a study of how did drug X work after CAR T cell progression or after bispecific progression, remember that there are patients who can't get on another study because they've been beat up by these prior therapies and might have chronic infections or cytopenias or other issues that you're seeing a selected patient population a little bit.
So let's finish out talking about mantle cell. And I noticed that you had the longer follow-up from your R-squared upfront approach. Everybody always brings up that paper. And those long-term data look awesome, as they always have. Any thoughts about that?
I remain excited about that, and I have patients in my clinic. I see 1 or 2 patients a month who are still on that study and long-term follow-up doing pretty well. So I think it is a good regimen. The question, really is that as a single agent, a BTK inhibitor is better than lenalidomide. And so, the field, while that was, I think, the first study to look at a quote unquote chemo-free approach, although obviously not a toxicity-free approach, I think it's a very nice regimen. And we've gone on to look, my colleague Gia Ruwan, at adding a BTK inhibitor plus lenalidomide plus rituximab, and have seen some good results. But ultimately, you'd have to do comparative studies to see there. But we remain, like in CLL, I think we're moving toward a chemo-free approach becoming more and more standard in mantle cell. That being said, I mean, BR for a lot of patients is still a pretty good regimen.
So, I always enjoy speaking with Michael Wong, and of course, he's a very pro no chemo, always been that way for a while. And you showed the data from Altamira looking at rituximab, which is a regimen he likes to use a lot. So he's able to do that. And then so I'm kind of curious how you think, and I think from his point of view and a lot of people's point of view, I guess it's kind of hard to separate Atacala versus Zanu, although you have to look at what the data is. But beyond that, they seem like potentially very similar options. Mm-hmm. Is this something that you actually do in your practice? Or do you treat some patients up front with BTK rituximab?
I think that the key message, so yes, I do at times. I think that the key message I take away is that if you're a high-risk patient, a P53 mutated patient, that's someone where chemotherapy is not going to work so well. And that person should probably pretty definitely, it's not a universal takeaway, but I think the community of mantle cell experts thinks that you should use a BTK rituximab kind of approach, maybe such as in the Bobin regimen with venetoclax as part of that. And we need to continue to explore those and see how durable they are. But we know that P53 mutated patients are not going to do as well. I think as far as using a BTK inhibitor, say with rituximab up front and not chemotherapy, I think the question is really, well, what happens when that patient progresses? You know that if someone gets BR and gets a 5-year remission or longer, which they're probably going to get, a BTK inhibitor is going to give them a great remission afterwards. So if you think about 5 years with BR and then several years with a BTK inhibitor, you've gotten decently down the road. And what are you going to do when that patient who starts on a zanubrutinib or a acalabrutinib progresses, we don't know if BR is going to work. Are you going to be heading that patient to CAR T, because that's all you've got left? So that's the concern I have. And I think that for lower risk patients, BR is a very reasonable approach. That said, these early data are exciting, and I think if we're going to use a BTK inhibitor up front, the clinical trial, the Alliance clinical trial that I referenced, that is really looking at, well, can you stop it after 6 months? That would be a great advantage if you can stop it after 6 months if you go into a CR, and then go for several years and then do it again and kind of go on and off therapy, cycling on and off therapy. That's a question that obviously is being looked at in CLL as well, because it's kind of the same sort of issues.
Been looking at prostate cancer. We did a program a couple of days ago. The intermittent endocrine therapy, even in metastatic disease now, is something that's out there on the table. You mentioned venetoclax in mantle cell, and I have seen that, and even in trials looking at younger patients. I'm not sure exactly where venetoclax fits in. Is it more in high risk patients? Where do you see it now? Where do you see it in the future in mantle cell?
I agree with you. I think the data really support it the most in the context of with a BTK inhibitor in higher risk patients. And I think by itself, it's not a particularly effective agent, but we do have some randomized data suggesting it can add to other agents.
So you also presented the study, I think it was a ECOG or intergroup study looking at transplant in mantle cell. I've been kind of wondering for years why people are so pro-transplant to start with, or high-dose therapy to start with. It's kind of hard for me to figure out. This is a randomized study, and the conclusion there was if they are an MRD negative CR, they don't benefit from transplant. I know that's the majority of patients, but of course hanging out there is what about the rest of the patients? How do you feel about intensive therapy, whether it's transplant or non-transplant approaches? How have you felt about it in the past, and how do you feel about it right now, post-triangle and everything else?
I was against it, and I'm still against it. I think is the takeaway. My colleague Peter Martin did an analysis back when he was a fellow, so this is decades ago, where he looked at patients treated with overall survival. I think there's no question that if you're giving chemotherapy, doing an auto transplant will improve progression-free survival. Not a surprise. More therapy, you stay in remission longer. But with regard to overall survival, if you looked at different series of patients treated with a less or more aggressive approach at a referral center, which is what a lot of the transplant data originally came from, the overall survivals were quite similar. And so we have not been as excited. I mean, we offer it to people because some people would say, well, gee, I want to stay in remission longer. And compared to some of the other approaches, that would accomplish that. But I think if you care about overall survival, that's really not going to impact that. We've thought for a long time, and I agree with. I think the issue of doing an auto transplant to just stay in remission longer is not very satisfying. I mean, it's a lot to put a patient through just to say, well, you'll go a little bit longer. And now that we have alternative therapies that are pretty manageable, like BTK inhibitors, that's become the standard of care really for at least second line therapy. And I think that's where we're going. I think to your question about the patient who doesn't get into CR, what are you going to do with that patient? That patient has fairly refractory disease that you could watch, but if you get a PR in mantle cell lymphoma to your initial therapy, you're going to be dealing with a disease again pretty soon probably, and that's somebody who's probably going to end up on a BTK inhibitor, and which probably can overcome some chemo resistance for that group of patients.
So, I was thinking about this idea that you were talking about intermittent BTK therapy, or stopping it or holding it. And I guess you could almost look at that as kind of like a time limited. Another way is to call it time limited. And I've got to sneak in a question on CLL here, even though I know we're talking about lymphoma, which is, what do you think about the amplified data? Are you doing it in your practice? Any thoughts about that? And do you see that kind of strategy potentially coming into mantle cell?
Yeah, I think the idea of, the challenge with the oral therapies so far is that you've been staying on them, you stay on them indefinitely. And so if the more we can get to a point of being able to say, can we stop therapy in a subset of patients and then is it safe to resume it at another point in the future, I think is a good thing for patients. I mean, that's the downside. That's the downside we talked about R squared earlier. I mean, that's the challenge there is that people stayed on it, and we didn't know how well it would work. But now you know that these agents work. Then you get into, if you're MRD negative or some other parameter, can you stop it? And then can you just resume it? And it's kind of, it goes back to the resort trial that Brad Call did in single agent rituximab in follicular lymphoma, 4 doses and maintenance, or 4 doses and then retreatment when you do it again. And at the end of the day, you got the same mileage out of rituximab with a lot less therapy.
Yeah, think about the CME days with the resort compared to CME days now, where like in an hour and a half, we still haven't gotten through all the key questions here. And you didn't answer my question about Amplify. Are you into it for CLL?
Yeah, I think we're moving in that direction.
So what about bispecifics in mantle cell? I heard people say that they're very effective, but also you see more CRS. Is that true? Do you see that coming into play with mantle cell? Where does pirtobrutinib fit in?
So I think the patient who relapses or progresses when they're on a BTK inhibitor, such as a acalabrutinib or zanubrutinib now, we know that pirtobrutinib has activity there. I think, it is meaningful activity for pirtobrutinib. This is the non-covalent BTK inhibitor that can work in patients that progress and on a BTK inhibitor. I think that's one option, but it's going to be limited. The idea that you're going to have years and years of response to pirtobrutinib, I think, remains to be seen. And so bispecifics have been looked at in clinical trials in mantle cell. I think the idea of using a bispecific after a BTK inhibitor is very attractive. We do have CAR T cells in that setting. I think the initial studies with bispecifics have largely been relatively small numbers of mantle cell, non-comparative, but meaningful activity. I think I've seen the most data in part with odronextamab, but more so even with glofitamab. But the other agents have a smattering of data there too. So there's no reason to think that a bispecific wouldn't work in relapsed mantle cell, but they've not, to my knowledge, gotten through the approval process yet in that setting.
So one more kind of final global question. Looking back on some of the things that we've talked about, and again, we focus today on follicular, diffuse large B-cell, and mantle cell, but within those diseases, curious, you see a lot of second opinions from patients who've been managed primarily in the community. When you think about these 3 types of non-Hodgkin lymphoma, any sort of myths or misperceptions or things you see people doing that you don't do?
I think with mantle cell, you have to keep in mind the watch and wait, that you can observe patients with mantle cell. And even if they're P53 mutated, I've had people with P53 mutated mantle cell that I've watched for a year or two. And, I've gotten smarter during that time. So I think with mantle cell, the big takeaways, I think we touched on the no transplant. And I think, really around the watch and wait is a key issue for mantle cell. I think in large cell lymphoma, people still struggle what to do with older patients. I think that ends up, I'm not sure that older patients end up in second opinions because they tend not to travel as much. But older patients, obviously, people are worried about them and trying to navigate that. They tend to have higher risk disease, partly because they're older, partly because they often have biologically worse disease. I think people also wonder about double hit lymphomas and how to navigate double hit lymphomas and approaches there. And then I think in follicular lymphoma, the key issues I think end up being kind of once you get through a treatment or two in the community and frankly in our own practice, because we debate these things, what would you think about for this person? We touched on this question earlier, but I think it comes back to being negotiating and collaborating with a patient to say, do you want more therapy, less therapy, more time off therapy, oral agents, et cetera? Do you want to go to CAR T cells? And I think the biggest the biggest thing that we can often do when we see those patients in second opinion is kind of help to give a little more color to those different options, because we use them a little bit more than somebody in the community, perhaps. But I think it's really trying to sort through all those options and figure out what works for an individual patient.
Just one follow-up question to what you just said. When you think about upfront treatment of older patients or patients with comorbidities with diffuse large B-cell, and again, seeing how people are being managed by other doctors, do you think there's a tendency to undertreat those patients, to overtreat them, or do you think people are getting it about right?
Yeah, I think it's a good question. I look back at how I've managed those patients, and I think back to a few times where I've overtreated patients. You probably want to undertreat someone a little bit the first cycle of therapy if you're worried, because you hate to kind of really impair somebody. I can tell you a patient of mine that I treated with a transformed double hit lymphoma, a lady who'd had breast cancer and prior therapy. And I said, well, let's give you one cycle of R-CHP because you have double hit lymphoma and I'm really worried about it. And I clearly overshot it. I mean, she came back and said, I thought she was pretty fit. But I gave her lowest dose of R-CHP, and that was a mistake. And, I came back the next cycle. I had to talk her into getting a cycle 2. And I said, let me try mini R-CHOP. Let me try that. I'll go from one end of the spectrum to the other. And, she did great with mini R-CHOP and finished it out. And I would have said, well, that's perhaps undertreating a double hit lymphoma, but she went into remission and did great. And, at some level, you don't want to put somebody into the hospital or put them into hospice in your grandiose plan. So I think, probably erring on the side of easing into it rather than overdoing it for a patient that you have questions on. And I think, in my experience, oncologists in practice have great judgment around this. People you've treated enough patients, this person's going to have a problem or this person can get through it.
This concludes our program. Special thanks to Dr. Leonard, and thank you for listening. This is Dr. Neil Love for Oncology Today.